Hi, Katie. Can you hear me okay?
Yes, I can.
Okay, great. Thank you.
Sure.
Do you want anything?
No, thank you.
Donuts and last few days of the month to cheat.
Good morning, everyone. I am Katie Martin Waldman with DCFS Planning and Evaluation, support to the Children's Subcommittee for the Commission on Behavioral Health. We currently have 2 members of our subcommittee. We still have 1 member of the subcommittee who we are waiting for. We do have quorum because the subcommittee is 3 individuals and we do have 2, so we do have quorum. If we could just wait another couple moments, it's Lisa Ruiz-Lee, and she did confirm that she would be able to attend. So if we could just give her a couple more moments before we start, that would be great. Thank you. And if at this time, if you have not already added your name and information to the chat, your name, your agency that you are representing, that would be great for us. Thank you.
All right, I see Commissioner Ruiz-Lee is on now, so go ahead and get started. Um, Apologies to everyone, first of all. It's my first meeting I've ever chaired, so I'm sure that I'll mess up the nuances of this along the way, but let's go ahead and call the subcommittee to order and get started. We're going to start off with our first agenda item, which is public comment. And I'll read the dissertation here about public comment. Members of the public may provide live public comment during public comment section of the agenda. Due to time considerations, each caller offering testimony during the periods of public comment will be limited to not more than 2 minutes. No action may be taken on any matter raised under this item of the agenda until the matter itself has been specifically included on the agenda as an item upon which can take action. To provide public comment telephonically, please dial 775-321-6111. When prompted to provide the meeting ID, enter pound 8141 pound. If providing public comment during Teams means mute your microphone prior to speaking, person making public comment will be asked to begin by stating their name for the record and spell their last name. Does anyone wish to make public comment at this time? Hearing and seeing none, we're going to close out that agenda item. Go ahead. Oh, I see some hands raised now. There we go. The first one I see is Dr. Hunt.
Good morning. For the record, Sarah Hunt, Executive Director of Be Here Nevada. I will keep this short, but per our, let me actually back up a little bit. So if you're not familiar with Be Here Nevada, we're a behavioral health workforce development center that was created in the 2023 legislative session from Assembly Bill 37. That bill requires us to create a yearly legislative report based on the calendar year, and we are required to submit that to the Commission on Behavioral Health per NRS 396.7938. We are asked to submit that report by June 1st, and I just wanted to report that we did send that report to the chair and the administrators of this commission, and wanted to just provide a quick overview of what is in that report. Hopefully you all have a copy of that. Again, we're tasked with kind of creating and recruiting and educating folks about behavioral health careers. And so some highlights from calendar year 2024 with regards to recruitment into behavioral health careers. We attended quite a few high school career fairs across Nevada, and were able to engage with over 1,000 high school students, some middle school students as well, to again talk about behavioral health careers and education pathways within the state of Nevada to pursue those careers. With regards to education, we have worked with several of our higher education programs to provide information to students enrolled in undergraduate and graduate programs about student loan repayment program options if they stay in Nevada after graduation. We also are working with the retention side of the workforce pipeline, with encouraging our students to stay and get licensed in Nevada. Some work we did in that area was to partner with UNR to provide tuition and fee coverage for a course that was offered this spring to increase the number of board-approved supervisors. So those licensed professionals across the state that had not received that supervision training completed that course. And I think we had 15 or 16 new providers that are now board-approved supervisors come out of that course. One other thing that we have done is we have a grant through the state to offer scholarships, and we have offered 12 scholarships to master's level students at UNR and UNLV in social work, in marriage and family therapy, and clinical mental health counseling, to provide tuition and fees for their 2 years of training. And we are about to issue 12 more scholarships coming up this fall. I think those are some of the highlights. One of the other pieces that we did this in 2024 was to bring on our new Associate Director for Technical Assistance and Policy. So we wanted to also be involved in this legislative session to follow any policy or legislation that would impact behavioral health workforce development. So she has been featuring some of those bills in our monthly newsletter. Those are just some things I wanted to touch on from the yearly report, and happy to answer any questions.
Great, thank you, Dr. Hunt. I'll just say that I was in that cohort that did the supervision training through the class at UNR. It was excellent. We have a new little cohort of clinical supervisors that program was really excellent. I think a lot of people that wouldn't normally have become supervisors are now supervisors because of that opportunity. And I know other people that have benefited from some of the scholarships. So great work being done by B here. Does any of the commission members have any questions for Dr. Hunt? Right. Was there someone else that had their hand raised for public comment? Go ahead.
Good morning again, everyone. I'm Katie Martin-Waldman, a professional support to the Children's Subcommittee. I just wanted to go back for a second and just acknowledge our 3 subcommittee commissioner members. We have our subcommittee chair, Dan Ficalora, our main Commission on Behavioral Health Chair, Braden Schrag, and our 3rd subcommittee member is Lisa Ruiz-Lee. And we also thank the remaining Commission on Behavioral Health commissioners who are also present today, and our presenters and regular attendees. So good morning, everyone. Thank you.
Any other members of the public for public comment today? All right, we'll go ahead and close out that agenda item and move on to agenda item 3 for announcements. I don't have any announcements myself. Braden or Lisa, do you have any announcements?
None from me.
All right. We'll go ahead and close out agenda item number 3 and move on to agenda item number 4, which is approval of outstanding meeting minutes. And we have a few to get through today. So I hope that everyone has had time to review. The first one that is up is the executive committee meeting minutes from April 11th, 2024, over a year ago. Has anybody have any amendments or changes to those minutes? All right. Would anyone like to make a motion to approve?
Commissioner Otbrayer, for the record. Sorry I'm late. Moving to accept the minutes as presented.
I have a question. Does it have to be a member of the subcommittee that makes the motions? Yeah.
It does. So I'll make a motion to approve. That's okay. Now we can add additional persons. Yeah. If we want later, we can add additional. We can add that to the next agenda item. We can add additional persons to the subcommittee. I believe Dr. Durrett would like to as well. And if there's anybody else, but I know for now it's myself, Commissioner Ficalora, and Commissioner Vice Chair Reesley from the Maine. So we can add additional, and we'll add that as a agenda item later on. Yeah.
So we have a motion approved by Commissioner Schrag. Do we have a second?
I'll second it, Lisa Reesley.
All right. All in favor?
Aye.
Aye. Any abstentions or dissensions? All right. So those pass as written. The next one we have is the DCFS public meeting from September 12th, 2024. Any changes needed on these meeting minutes? Do we have a motion to approve these ones?
I'll make a motion to approve as submitted.
Great.
I'll second it.
All in
I'll
favor?
second.
Aye.
Aye.
All right. Any abstentions or dissensions? Nope. Okay. And last one is the meeting minutes from September 26th, 2024. Any edits needed on these ones?
No.
No. A motion to approve?
I'll make a motion to approve.
I'll second it.
All in favor of approving as written?
Aye.
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 Any abstentions or dissensions? All right, and those are approved as well. That will close out agenda item 4, and we'll move on to agenda item 5, which is the annual report presentation from the Washoe Children's Mental Health Consortium. Annie Zucker, are you on the line?
Good morning, everybody. Thank you so much for allowing me to present today. Am I allowed to share a screen?
Yes.
Okay, perfect. Share. Can you all see my screen now? Okay, so I'm here today to give a report for the Washoe County Children's Mental Health Consortium 2024 annual report and overview. The purpose is of the Washoe County Children's Mental Health Consortium is to share progress, gaps, and future goals in strengthening the children's mental health system in Washoe County. The mandate was established under NRS 433B to improve outcomes for children and youth with emotional and behavioral health challenges. The vision is a community where all children and youth have equitable access to compassionate, family-centered mental health care with a mission to drive systemic improvements that ensure timely, effective, and coordinated behavioral health services. Key policy drivers for 2024. Key policy drivers still for the year 2024 was the U.S. Surgeon General's advisory in 2021, which emphasized the need for empowerment and equitable access. The DOJ settlement in 2022 that called for a community-based service expansion, and the Silver State Health Plan 2023 to 2028, which prioritized mental health, equity, and infrastructure. Some systemic progress in Washoe County was that the mobile crisis response team is now localized under Washoe County. $19 million secured for the 988 Crisis Lifeline expansion in Nevada. And we've had significant mental health resource fairs and cross-system collaboration initiated in Washoe County. Persistent challenges likely in the entire state of Nevada is workforce shortages, low Medicaid reimbursement rates, and lack of respite care and specialty services for youth with ID and DD. Some community-driven highlights. We are moving into the 4th annual Youth Mental Health Summit that is really hosted by the entire community. It's driven through the Children's Cabinet and Connect Washoe County, but really emphasizing last year on the youth voice with teen panels that were following the subject matter experts for the day, and it's been really successful. We have our 2024 coming up on September 23rd this year. We've expanded school-based behavioral health supports, and then our partnerships with UNR, Nevada PEP, and Health Psychology Associates continue to grow. Some strategic recommendations this year is to sustain and expand our local programs, fund $65,000 for System of Care Coordinator, and develop trauma-informed respite care services, and continue to look into that and expand those. Looking ahead for our 2025 initiatives, continue our cultural outreach via Acá Entre Nos, our peer support in schools with Washoe County School District and the Children's Cabinet, and then continue our data tracking and collaboration. Our call to action this year is for policymakers to invest in funding and workforce, providers to engage in more system building, and community shared lived experience and advocates. And that's all I have for our report. We have submitted our report and it has been accepted. And we look forward to 2025 and beyond.
Great.
Any
Thank
que-
you, Annie, for the presentation. And any questions from the subcommittee members?
No.
Thank you so much. Moving on to agenda item 6, for information only, a presentation from Psy Mental Health Residential Treatment Center, Jeanette Bussey, CEO.
Hi, good morning, everyone.
Morning.
Thank you for allowing me to join your meeting and talk about our program. We are focusing on the overall program, giving some education and knowledge about our program, and also touching on restraint policies. So I will go ahead and get started. Please feel free to jump in if you have any questions at all. Okay. So I'm going to share my screen. So Psy Residential Treatment Center was opened in June of 2023. And I will say we had no idea what we were doing. And we had big plans and were very hopeful. And we fell and bumped our butts several times in the past couple of years. But over those years, we have learned a lot, and we continue to grow and try to provide the best services possible for the adolescents in our community. This is just a picture of our leadership team. So I am the CEO. Our physician is Dr. Ryan Lay. We have Marisol Caro as our operations manager, Amy Roman Bello as our house manager, Lacey Lorenzo, LCSW, as our clinical director, Sarah Wheeler, RN, as the nursing manager and compliance manager, and Colton Wagner as the mental health tech supervisor. So this is the mission statement that we've created to provide individualized, supportive, and compassionate care to teens who are suffering with mental health and substance use symptoms. The Psy-RTC team believes in treating each person as a whole by identifying the underlying core issues that may be causing or contributing to their mental health and substance use. We believe this will help each person heal physically, spiritually, and mentally. It is our goal at Psy Residential Treatment Center to help patients find the tools they need to achieve and maintain long-term health. Just a little bit about our program. Like I said, we've been open since June of 2023. We are in an actual house in Northwest Reno. And a reason for that is that when we opened the program, we had worked in a lot of facilities, hospitals, and we just wanted to do something a little bit different for the adolescents in our community. So we opened it in an actual home up in Somerset, which I don't know what you guys have heard, but I guarantee our neighbors absolutely adore us. And that's sarcasm. You know how that goes. But we have a nice house in a nice neighborhood. We work with adolescents ages 12 to 17 with co-occurring issues. Primarily, I would say mild to moderate mental health. So we're seeing a lot of major depressive disorder, generalized anxiety disorder, post-traumatic stress disorder, and many of them also come in with substance use diagnoses. So we provide that co-occurring treatment. We do have a 10-bed facility, and We offer treatment for mental health and substance use. Every adolescent who is part of our program participates in at least 2 60-minute mental health sessions per week with a licensed therapist. If they have a substance abuse diagnosis or they are at risk for substances, they meet weekly with a substance use counselor. We have at least 1 family session per week. And we have groups throughout the days. So we have therapist-led groups on DBT topics. We have life skills groups. We have a trauma-informed yoga therapist who comes in twice a week and does a group with them. We have a music therapist who comes in twice a week and does group with them. So they have lots of stuff that they're doing. They are also being treated by a psychiatric physician while they're with us to provide medication management. Any questions so far? Okay. So I'm not going to read this completely, but I will just explain our core values. We are a person-centered treatment facility, which means that we believe that the client, the adolescent, is part of their treatment from beginning to end. So they take part in every step of the way. They engage and participate in their treatment plan by identifying what they believe their own problems are, and they also identify their own goals and objectives, led by a therapist, and we also have the therapist providing goals and objectives as well. The adolescent is involved in every step through the process. We are there to support the client and the family and help give them tools to handle their mental health or their substance use, but also the family issues that come along with these things as well. Our staff goes through quite a bit of training, actually. So I'm just going to go over this briefly. All of our direct service staff, which means our therapists, our mental health technicians, our nursing staff, our chefs, everyone across the board has to complete a company orientation on policies and procedures. They have 20 hours at new hire of residential treatment specific training. They have 10 hours of supervised in-person training on the floor in the house, and that is done by our mental health tech supervisor. And they have, this is just a few of the types of trainings that they go through: suicide prevention, human trafficking, conflict resolution, verbal de-escalation, effective communication, but there's loads more that they go through as well. We also assign position-specific training. So like with the therapist, the clinical team, they have certain training requirements that they have to go through specific to their position, as well as our nursing team and our MHT team. All of our training modules are competency-based. So we do have a majority of our training online with Relias, and they test at the end of each training and measure competency in the subject. This is just a few expectations of our positions. So we do have a mental health tech position. The mental health tech position is, they are the ones who are with the clients the most. They are on the floor at all times with the clients throughout the day and the night. We are staffed 24/7. And these are the techs, or these are the staff who move with the clients, make sure they're doing the program they're supposed to be doing, make sure that they are staying safe, observing their behaviors and their motivation. They play a very important part in our facility because we do have a team-based approach. And because these mental health techs are with the clients so much more than any of the other staff, They do have a responsibility to make those observations of behaviors, attitudes, statements. Sometimes the kids will tell them a lot more than they tell even their therapists. So the mental health techs are trained pretty comprehensively on how to react if a patient tells them something or has a certain behavior that they know to go to their supervisor or to the client's therapist. So they just basically hang out with the kids all day and help them with their programming. We also have nurses. So we have one RN. We're bringing another RN on. We have 2 LPNs and then we have medical assistants. So we have our RN who is our nursing manager, and she is also the only one who administers controlled substances. And then the LPNs and the medical assistants just take care of minor medical issues. They do vitals, they do nursing notes, they do nursing groups on health-related topics. They educate parents and families about medications and diagnoses and any medical issues that may be occurring as well. And then we have our therapists who meet with the clients several times during the week. They do intake and risk assessments for incoming clients. They do ASAMs every 30 days, treatment plans, transfer and discharge ASAMs, diagnosis and level of care recommendation, person-centered planning, and mental health and substance abuse for individuals, families, and groups. I should add, and I don't know if I added on this, I feel like I left it out, but each resident at our home also has a weekly treatment team meeting. And the treatment team consists of the child, their parents or guardians, if that is appropriate for that case, their therapist, the clinical director, a member of our nursing staff, a member of our mental health tech staff, and the physician. They meet once a week to go over progress towards treatment goals, successes, challenges, expectations for discharge, and answer any questions related to the treatment. Okay, some of our challenges are the ongoing neighborhood disapproval of our program. We have tried everything that we can possibly think of to build a relationship in that neighborhood, and they have not joined us in the middle. And they continue to call every single day, and I mean that, to the city of Reno, to the state of Nevada, and file complaints. The state of Nevada will respond to our facility and tell us that they don't know what to do. It's borderline harassment at this point. They're clogging up the lines at the state of Nevada with their complaints. 98% of them aren't even worth investigating, according to the state of Nevada. They have, published articles in local publications about our facility with accusations that are so wildly outrageous. That our patients have drugs and guns in the house and everything else. So that's probably, I would say, our biggest challenge at this point, is they really believe we are doing something evil to these children in our home. Police and EMS calls continue to be a problem. I recently, and I'm just being transparent here because we're all in this field and we understand we're all doing the best we can, and there's some challenges. I recently got a phone call from Reno Police Department saying they're conducting an investigation into how many police and EMS calls we're getting at the house, and that they're looking at possible residential neighborhood disruption. And I just, off the top of my head, I said, hey, do you guys have caller ID? Do you know how many of those calls are actually coming from our house versus how many are coming from the neighbors. It was kind of funny. She started laughing. She goes, actually, we do. I never really thought about it that way. I said, hey, look at those numbers for the phone calls, and you might have a better idea of where those phone calls are coming from. So we try to limit our police and EMS calls as much as possible. We only call the police or EMS in extreme situations where a child is a direct risk of harm to themselves or someone else. Other than that, we have training and processes in place to deal with behaviors that come along with these diagnoses. Support from the city of Reno, retaining qualified staff, and lack of parent involvement. Some of the mitigation measures that we are working on to help solve the issues. We are offering community meetings in the neighborhood. So we have passed out flyers in the neighborhood, asking them to join community meetings to learn more about our program, hoping that if they know more about what we are doing, they will understand more and not think that we are the enemy. No one has ever signed up, but we continue to offer them. We are attempting to have personal discussions with neighbors. So I will walk up and down the neighborhoods, and if they are outside, I will introduce myself, ask them if they would like to know more about our program. Some of them have actually been responsive to that one-on-one personal discussion. So we're really trying to provide some education about our program. We are working on building a relationship with Reno Police Department and Reno MOST team. So I've been in contact with Christy Butler, and I've known Christy for many years. And we are working on a partnership with Reno Police Department, where the MOST team will come out and do periodic de-escalation trainings for our staff, as well as doing some educational meetings with Reno Police Department on our program. We are doing additional screening and hiring more people with professional knowledge and experience. So one of the lessons that we learned was that we were hiring a lot of mental health tech positions that were young, they were unexperienced, they were eager, but they did not have the knowledge and the tools to deal with some of the kids that we work with. So we are screening on a higher level all of the applicants, and we are hiring people who have experience, knowledge, people who were in school for mental health, those kinds of things. We do have weekly parent and guardian support system educational groups online, and our parents, that group is actually really growing because it's very scary when your kid is away from home and in a program and you don't know what's happening. So they join online once a week, and we take turns running that meeting. So I will run it one week, our clinical director will run it one week, our nursing manager will run it one week, and we just go over topics that are relevant to them as a family. We go over, mental health diagnoses, medications, behaviors. We give the parents some tools and tips on dealing with these issues and challenges. They're able to talk amongst themselves and build relationships with one another, and kind of see that they're not alone in this situation, and that support from other families can benefit them. We do send out monthly newsletters to all of the parents with the cool things that their kids are doing in the program, and they enjoy those quite a bit. And then we just recently hired a case manager who is handling a lot of the parent and family issues and questions. Okay, so this is, and I'm not the best at PowerPoint, so I just put our policy on here. Cy Residential Treatment Center is a no restraint and seclusion treatment center, sorry. We do not practice seclusion and restraint at our facility. We originally tossed it around as an option, but ultimately with the guidance of the state of Nevada, as well as our accreditation with CARF, non-seclusion and restraint programs are being more encouraged across the country. They are, encouraging less and less of these seclusions and restraints. So we have we let everyone know we are a non-seclusion and restraint facility. Sorry, I can't talk today. We do not put our hands on those children for any reason unless they are, again, a very, very acute risk of harm to themselves or others. And in that case, all of our staff is trained extensively in verbal de-escalation as well as safe restraints. That is the last resort, though. So we have seclusion and restraint is not used as a safety intervention. In the event of an imminent danger to the patient's self or others, staff will follow these procedures. Our first response is to attempt to de-escalate the patients in any way that we can. If that is not possible and they are an acute risk to themselves or others, we will call emergency services. In the meantime, our staff has been trained to de-escalate the situation. They remove the child or the children who are a risk to themselves or others, and our other staff takes the rest of the kids somewhere else. We make every effort to remove the person in crisis from the immediate area and his or her peers. Oh my goodness, that's awful. Okay. I can't make that. So this is just our seclusion policy, and it just basically says we do not provide seclusion and restraint. In the event that a person served displays unsafe behaviors, we attempt to engage the person served in self-soothing techniques such as mindfulness, emotional regulation, sensory experiences, peer support, and visualization. If techniques are not successful, the person served will be assigned to a limited timeout in his or her room. Timeout should never exceed 20 minutes. Complete room checks every 5 minutes to ensure safety of person served. Person served may return to activity once he or she has self-soothed and behaviors are no longer dangerous to the self or others. If timeout is not successful or the behavior is escalating and or is dangerous to the self or others, the person served will be assigned to a limited time in a safe room with a therapist. So this is not, we don't have a seclusion room. Our safe room is the therapist office, one of the therapist office, and they will sit in the therapist office with a clinician and just try to soothe themselves. So we have a policy. I'm not going to go through and read this. If you want me to send this PowerPoint to you, I will. But this is basically saying that we have to have written orders for any incidents of seclusion or restraint if we get to that point. So we have to call Dr. Lay and we have to receive an order for that. So same thing, our staff is trained to only utilize seclusion as a safety intervention to prevent harm to the person served. A documented training on seclusion techniques is provided to all direct care staff. We do, as I said, we do provide training on seclusion and restraint to every employee, just in case of worst case scenario. They all understand that that is the last resort. And in the 2 years that we've been open, I think that we have had 2 restraints happen. And that was the 2 children were at absolute risk to themselves, and they had to be restrained for their safety. So we do have training on verbal de-escalation, and they are trained in that quarterly and as needed. And then we have our handle with care training for safe restraints at orientation annually and as needed. So our training does involve the risks of seclusion and restraint, not just on the physical aspect of it, but we do train our staff on psychological risks like re-traumatization, loss of personal control, anxiety, claustrophobia, dissociation, loneliness, and feelings of exclusion. We do have leadership debriefing if there's ever a time that we have a seclusion or a restraint that occurs. The leadership team meets immediately and debriefs the situation, analyzes it for, what was done well, what were challenges, what education and training specific staff may need as a result of, how it went. And then each of the department managers goes on to debrief with their staff about the situation. Okay, that's it. So does anyone have any questions about Sci Residential Treatment Center or our restraint and seclusion policies?
Dr. Drake?
Yeah. Hey, Jeanette. I have a couple of questions. With regards, let me put my hand down, to the youth that are in your facility, how are they getting referred, and are you accepting Medicaid? Is it private pay? What's the situation?
Yeah. So I'll address the insurance policy or the insurance question first. So we have, over the last couple of years, we've obtained contracts with almost all of the private insurance companies. And so we accept all private insurance companies. And then last year, we had to get at least a year CARF accreditation, which if you're familiar with CARF, it's a national accreditation. So Medicaid requires that accreditation before they will provide us with a contract. So we obtained that last year and we jumped on it and we got a contract with Medicaid fee-for-service. So the managed Medicaids we're still working on, but they have been amazing for us. And our insurance authorization team are usually able to get single case agreements with, I know for sure, Health Plan of Nevada, Sierra Summit, Anthem is hit or miss. We have to do some pretty hardcore work to get a single case agreement with Anthem Medicaid, but we're working on it. Our main priority was to get that contract for Nevada Medicaid, since a lot of our adolescents in this community are on that plan.
So of the 10 youth that are in your facility, what percentage are Medicaid recipients?
I would say now, I would say probably, it's close, probably 40 to 50% are Medicaid recipients.
Okay. And one other question, I saw that Annie also had her hand up. What's your average length of stay?
Average length of stay is anywhere between 60 and 90 days, but it is all based on an individual program. So we have had kids stay for longer than 90 days. We've had kids complete the program in 30 days. Our average length of stay is 90 days though. And that takes into account that first month is really just an adjustment for the child and the family. And that's where we see most of our defiance and resistance to treatment and those kinds of things. And then once they kind of settle in, and we usually see that around 3 weeks to a month, and they start recognizing that they have to, they want to go home so badly, they have to, meet certain criteria to be able to go home. So they have about 60 days where they're into the program, they're doing the program, they're participating, and most of our kids are ready to go within 90 days and they transition to a lower level of care.
And I'm sorry, I have one last question. You didn't mention how you get their educational needs met. Are they enrolled in local schools, or how are you achieving that?
I also didn't address your referral question, so I'll do both of those. So we get most of our referrals from providers in the community. So a lot of referrals from Reno Behavioral Health. We have a couple of hospitals down in Vegas who are sending us referrals. We have created partnerships with many of the county juvenile probation departments. So Washoe County, Douglas County, Lyon County. I know I'm missing a few, but we get a lot of referrals from juvenile probation. We also have a partnership with Nevada Youth Parole. So we get referrals from Nevada Parole. And then we have just some stragglers who we have, Thrive Wellness sends us some, Quest Counseling, so different providers around town. And then, of course, we have the self-referrals, parents who just call and inquire about the program. As far as their educational needs, every child who is in our program is enrolled in accredited online educational program. Cy Residential Treatment Center covers the fee for that program and their tuition when they are with us in treatment. And the program is called Advantages Digital Learning System. So they will do we have to get transcripts on admission, provide them to Advantages, and then they will place them in the appropriate level of classes. They also work with children who are on an IEP or have fallen behind in their educational studies. They give them placement exams to determine what level they're at and then place them in the appropriate courses. They also provide one-on-one peer tutoring and independent time with teachers when the kids are extremely behind and they need more support. So we have the kids have 3.5 hours a day that they are doing education time. Okay, Annie?
Hi. Yeah, I was just wondering because I know that there's been attempts at residential treatment homes in the community. How is this penciling out financially? With as much staff, it's just amazing how much staff and support that you have for these kids. And I'm just wondering how it pencils.
Well, I'll tell you, and I'm not the one that hits, our owner. The first year was really tough. And I know he was really struggling that first year. And I believe that we are making a profit at this point, not a huge one. And, I'm really fortunate to work for people who that is not their main priority. Their main priority is to provide treatment. And if they make a few dollars on top of it, and that's really about it. I mean, we're not making a huge amount of money at this point. But we have been very successful. I will tell you that. And we are preparing to open a second home. So that kind of shows that we are doing well in the community. We have a lot of support in the community. And our referral sources are growing, and the treatment that we're providing is, and I don't just say this because it's my program, it's pretty good. And, I know that there's always going to be people who have stories and things that they don't like about us or things that they've heard or those kinds of things. But I will tell you that we give everything we are to these kids, and we really try to have a good program for them and their kids. So or their parents. So we're getting ready to open a second home. This home has been co-ed, and I should have put that as one of our challenges. I don't know what we were thinking when we did that. That has not been fun because there is always some sort of romance blooming at Cy Residential Treatment Center, and so we're having to manage that as well. So when our second home opens, we are going to be splitting the genders. So one home will be for female clients, the other one will be for male clients. So to answer your question, I guess we're doing okay. We're hanging in there.
And ages, what is your age gap?
12 to 17.
12 to 17.
Any other questions?
Thank you so much for the presentation. Is there any other questions from the committee? All right. Thank you so much, and keep up the good work in your community. Thank you so much.
Thank you. Thank you, everyone.
Okay, moving on to agenda item 7 for information only, Medicaid updates and changes. Sarah.
Hello, good morning, everyone. I will share my screen. All right. So thank you so much for having me here. It's great to be back and present kind of what's going on at Medicaid related to behavioral health. So today I'll just review a couple general Medicaid updates, not very specific to behavioral health, but touch all Medicaid providers. Also, I'll review a little bit about the work that's happening with our children's behavioral health transformation, as well as the current state plan amendments that are under review with CMS, and then our upcoming proposed changes to Medicaid service manuals. I'll briefly review what's happening with our current 1115 demonstration for SUD treatment within an institution for mental disease, and our proposed amendment that we have under review with CMS for that demonstration. And then quickly review just a summary timeline of projects happening in the next couple of months. But first, I like to start with some just general Medicaid updates. Again, these are not very specific to our behavioral health benefits team, but definitely impact providers performing services. So if there are additional questions on any of these areas, I'm happy to connect people to the right staff at Medicaid. So the first I just really want to bring awareness to is our road to statewide managed care. Our new statewide managed care contracts were awarded, and those will begin January 1st of 2026. I can provide Katie and Carrie this presentation as well afterward, and where you can access the links. But on our main DHCFP webpage, you can access our managed care page as well as some of the others I've mentioned. The next is our new provider enrollment solution. It's called Provider Flex. There's a couple web announcements on this, and this is intended to really support providers when they're enrolling in Nevada Medicaid. It's going to include things like DocuSign rather than requiring wet signatures on enrollments. Because Medicaid has so many various provider types, this is happening in phases. I believe provider type 14, which maybe some of you are familiar with, is our behavioral health outpatient treatment provider that should be rolling out in our Provider Flex module this summer. But again, if you have some specific questions, I'm happy to connect you to those people. Additionally, I want to mention our Justice Involved Reentry Program webpage. There is a whole lot of work happening in the Justice Involved Reentry programs. I'll talk a little more specifically under our current state plan amendments we have, but also want to draw attention to Nevada also has applied for an 1115 reentry waiver that is under review with CMS, and that will essentially provide some, not just some behavioral health services, but also medical coverage for treatment for individuals that are incarcerated 90 days pre-release. Again, this is under review with CMS, and we're hoping for approval of this hopefully by fall of this year, but really an exciting project moving forward for Nevada. Next, I'll talk a little bit about our behavioral health, our children's behavioral health transformation. So many of you have seen this infographic on the right several times. That's kind of been our leading infographic of really what Nevada is hoping to do with a lot of work around children's behavioral health services. Of course, many of you know this has all been kind of initiated by the Department of Justice settlement agreement. Nevada was able to come to a settlement agreement with DOJ the beginning of this year, I believe January 2nd of this year. But we have been working hard to transform our services even before that. Our main focus right now is really expanding our peer support services. So we'll be adding in family peer support and youth peer support. just really recognizing the value in these types of services to support not just youth, but also their families throughout the treatment process, and really utilizing the service as a way to really maybe encourage or that may be the front door for services as well. Currently, our peer support policy lives within chapter MSM 400. What we've done as we've expanded these services, we've created a brand new Medicaid Service Manual chapter, chapter 4300 for peer support. So it's going to outline adult recovery peer support services, and then also highlight family peer support as well as youth peer support. Additionally, with the new Medicaid chapter, we've also built a brand new provider type very specific to peer support. So right now, Medicaid does allow an individual enrollment for certified peer recovery support specialists. Building this new provider type will allow peer-ran organizations, for example, that want to provide and really focus just on peer support to become a Medicaid provider. And then it will also require all individuals performing peer support services, whether that's your, if your focus is adult recovery peer support, or your focus might be family peer support, or your focus might be youth peer support. We've also developed some different specialties for that. So we're hoping this new provider type should be available this summer for interested providers to enroll in, and kind of going along with our new Medicaid chapter. And then we're also submitting a state plan amendment related to peer support services. I'll get into that in just a moment as well. The next piece is we've also focused on some increased rates for our existing children's behavioral health services related to psychosocial rehab, basic skills training, our individual and family therapies as well. So really looking at our current services. Initially, when we were looking at all of our services, and some of you may have participated in a public workshop back in March, where we were really excited to bring some rate increases to all behavioral health outpatient services. But since then, our federal climate has looked very different. So we've had to kind of reorganize the phases that we're rolling out rate increases. So right now, our current focus is really on the children's behavioral health services that were, those rate increases were approved at the interim finance committee, I believe April of last year. So that's really where our focus is right now. And then hoping for a phase 2 rollout of some additional rate increases around not just children's behavioral health services, but also adult behavioral health services, as well as some SUD treatment services. So that phase 2 hoping to come out more in the fall time. Of course, also pending on everything that happens federally as well. So this slide also kind of reviews a lot of the work we're doing on some rate reforms. So not just our children's behavioral health outpatient treatment that I've already mentioned, but we also have some current state plan amendments that are under review that are supporting a lot of the work we're doing in children's behavioral health. The first being our provider type 13, which is our inpatient psychiatric hospital facilities. We wanted to make sure that those rates were in alignment with our general hospital psychiatric treatment as well. So prior to this state plan being submitted, our provider type 13 inpatient psych hospitals were all reimbursed based on a negotiated rate. So we wanted to really align that with our provider type 11 and raising those provider type 13 rates to the $944. This state plan amendment is under review with CMS. It's really being led by our rates team, not necessarily our behavioral health team, but I like to mention it because it's all related to behavioral health services. The next is our provider type 63, which is our psychiatric residential treatment facility provider type. So these providers are all reimbursed based on a negotiated rate as well. So what we're doing here is we've proposed a state plan amendment with our federal partners at CMS to create more of a flat rate for all of these providers, so an $800 a day rate. And then for those facilities that are providing services to individuals qualifying as behaviorally complex, it would receive an additional add-on rate of $150 a day. We're also doing a lot of work on designing some quality incentive or quality bonus payments that we're looking to be able to tie to quality metrics to really ensure quality of delivery of, as we consider one of the most highest acuity levels of treatment. We want to ensure that these providers are performing great services as well. And then the last I've already talked about. So even though this date has expired, I do like to leave this slide up. So a lot of the work being done under our Children's Behavioral Health Services, and hopefully some of you are joining those advisory work groups. Those happen every month, really specific to children's behavioral health. But what we're hoping to do is develop a specialty managed care plan to really harness the children's behavioral health as well as their medical behavioral health services for children that are identified as being under the focus population within our Department of Justice settlement. So this is really at the beginning stages. We are hoping to roll out a specialty managed care plan, I believe January of 2027. So again, these initial phases are really a request for information. So we were hoping to get feedback the end of May. I think right now our children's behavioral health team is really working on kind of gathering some of that feedback that was collected during that request for information process. I do want to mention again, just our youth reentry services. So there's a couple of requirements that are all related. So the Consolidated Appropriations Act of 2023 required states to cover screening, diagnostic, and targeted case management services for eligible juveniles that are eligible for these services 30 days pre-release. And this was a requirement for states beginning January 1st of 2025. So we have submitted some state plan amendments to assure that we're complying with this requirement. There's, of course, a lot of build out that has to occur, and partnerships that have to occur in working with our juvenile services, as well as some state plan amendment approval. What Nevada is also doing to kind of make this requirement a bit more robust was during the last, I believe, the 2023 legislative session, Assembly Bill 389 required Nevada to apply for an 1115 reentry waiver. And so what this reentry waiver will do when it's approved by CMS is it's going to expand the population to not just eligible juveniles, but also all individuals that are in a carceral facility, and will also expand the services available. So it will expand the population, the services available, and then the time period that those individuals can also receive services. So it will allow for services to be eligible 90 days pre-release. So will include targeted case management, screening, and diagnostic services, but also will include some behavioral health services included, with the goal to really support reentry into our communities and reduce recidivism as well. This is under review with CMS, but I would encourage everyone to read the application that we have. There is also an advisory work group on this subject as well. I believe the last one was this Tuesday, and that occurs every month as well. So encourage folks to get involved, and these are all public meetings as well. So now for some of the slides you're probably a little more used to. These are our current state plan amendments that we have under review with our federal partners at CMS. The first is specific to our application renewal of our 1915I program that is specific to specialized foster care. There's no new services included in this. This is really just an application approval. 1915I programs have to be renewed every 5 years. So we are working with CMS on that. That has not been approved yet. The next is our newest benefit, which is our health home benefit for Medicaid beneficiaries with fetal alcohol spectrum disorder. This is a really new benefit to Nevada. And I always describe it as really being kind of care coordination, case management on steroids. It really wraps the individual in all sorts of different types of care management services so that they're supported in getting the treatment that they need. This is on pause with CMS, so as we call it, request for additional information. And we are working through this, but once approved, this will be a new provider type specialty under our applied behavior analysis provider type 85 for health home groups that really include lots of different behavioral health professionals and medical professionals as part of the team to support individuals in care management services. The next briefly mentioned is more specific to our targeted case management as it relates toward the requirements of the Consolidated Appropriations Act. Medicaid had to include a brand new target group for eligible juveniles to meet those requirements. So that's under review with CMS currently. The two upcoming Medicaid service manual updates we have that we're looking forward to on our June 24th public hearing agenda are related to peer support. So again, integrating that new Medicaid chapter 4300, and then taking peer support out of 400. So that's what these changes will do. If you're interested, our public notice website has all of the draft language out for public comment currently. It's all posted on there, and I can put that in the chat, the link to our public notice website, once I'm done. I'm not great at multitasking. All right, briefly, want to talk about our current 1115 that we have. So our current 1115 allows for substance use treatment within an institution for mental disease. So these are more of your residential levels of care within ASAM, so your 3.1s, 3.5, and 3.7 levels of care for providers that have over 16 beds in their facility. So this is up and running. We have bundled rates for those types of ASAM levels of care. Now what we're doing, since we have a handle on this, we have submitted an amendment to CMS to this waiver to allow for SMI treatment in an acute setting. So that will, once that's approved, then we Medicaid will be able to reimburse for services, psychiatric services in an acute IMD setting. We've also included some proposed services around health-related social needs, also heard and talked about as some supportive housing services as well. We are working through this with CMS. This has been delayed a bit and isn't expected to receive approval until late this calendar year. It sounds like CMS is really focused a lot more on our reentry waiver currently. So we are hoping for approval of this at the end of the year. We are also looking to a possible amendment, an additional amendment to this 1115 to account for allowing for a single specialty managed care plan as part of our children's behavioral health work. So if that sounds like a lot for an 1115, we are learning every day about all the different authorities that the federal government has to offer and how we can really be creative with the services and flexibilities we can offer at Medicaid. The last slide is really just a picture of what kind of we're working on. it looks so bare. Usually this is very filled up, but our teams are very hard at work at legislative session right now. There are a lot of great and creative behavioral health bills that are being proposed that are still alive as well, that we're working through. So our teams will be very busy with implementation and approval, hopefully, of some of those bills. We're also working a lot on our children's behavioral health work. We do hope to have, and if any of you have attended, we do try to present the end of legislative session public hearing where we review all the bills that Medicaid has been impacted by. There are several out there, so not just specific to behavioral health, but our whole Medicaid team really tries to come together and provide a good workshop on what's moving through the legislative session. So that is about it for me. I'll pause and see if there's questions, but I'll leave it on our slide too in case anyone needs to reach out with specific questions.
Thank you so much, Sarah, for the presentation. Any questions from the subcommittee? Okay, have a great day. Thank you so much.
Thank you.
Moving on to agenda item 8 for information only, autism treatment assistant program update from Rachel Metz of the autism treatment assistance program.
Good morning. Thank you. So I am giving the updates for our program. We have seen with the new referral system from No Wrong Door, we have been seeing a large influx with referrals. Our monthly caseload for April of 2025, we've seen an increase with 271 new applicants. Our average wait time right now is about 45 days. We have also, through our budget, all our services are funded. And we also have seen no growth with new BCBAs, but we do hope that after graduation that there will be some increase. And we are pretty much just plugging along and providing services. And so that is our updates. Any questions?
Thanks so much. I do have a question.
Right. Yes.
You noted that they had an increase in referrals. Do you have
Correct.
any insight as to where those new referrals that weren't there before, where they're coming from?
Through No Wrong Door. So we are through the No Wrong Door portal. We have been getting an influx with a lot of self-referrals. Typically, we would get referrals from NEIS and the diagnosing clinician. But now with the No Wrong Door, parents and the community are more aware or becoming aware of our program. And so there has been, that's the influx.
Great. Thank you so much. Dr. Dredd?
Thank you.
Hey, Rachel, you mentioned this No Wrong Door a couple of times, and
Yeah.
I'm somebody that does a lot of these referrals, and I'm not familiar with it. So could you please share this resource and explain what exactly it is?
I am not that proficient with it as well. So, but I will give you a little bit of information on it, what I know about it. As far as I know, it was a opening through the state to open up more access to parents who have children with ASD diagnosis to kind of get the name, to get services out there. And so parents go on and they answer questions. And if they tick certain boxes with autism, they automatically get referred to our program. And then they do go through that intake. Many of our referrals, they do think that we are providing that direct one-on-one services. So through our intake process, we're able to see if our program is a fit for them or if they're, sorry, I lost my train of thought. if our program is a fit for them, if it's what they're looking for. If it is, we continue to go through the intake process. If not, we do try to direct them to what they may be looking for.
And this is Kyra Morgan with DCFS. Generally speaking, No Wrong Door is just a portal that DHHS is standing up. I think Aging and Disability Services is the lead on that. But the idea is just that a person can go to one location and put in all of their information, and they can then be sort of maneuvered to services that they would qualify for, so that they wouldn't have to go to welfare's website to sign up for Medicaid, and then, you know, public and behavioral health to sign up for WIC, and then ADSD to sign up for those services. The idea is that there's one centralized location that Nevadans can go to for like a wide array of social services and put their information in once. And then that information can qualify them for a number of different programs rather than having them go apply for all of those programs individually. So the idea is that No Wrong Door, there's one door that they go in, and that door opens them to services across a spectrum, again, versus having to do those in onesies.
Thank you. And so does the family themselves have to apply, or could a care coordinator or case manager do the process on behalf of a family?
I don't know the answer to that, but I think either way, I'm on the website, the Access Nevada website, which someone did drop into the chat now, and I haven't actually gone through it myself personally. I think probably if you were sitting with the family, you could do it on their behalf, but there may be some attestation and that I'm not aware of that wants, you know, the family themselves to put in the information. But I would say, to the extent that a care coordinator could assist a family, I wouldn't deter you from doing that.
Yeah, that was my understanding as well, and thank you, Kyra. It was that usually most of the people that are coming through, it is through No Wrong Door. It is through that self-referral, but they have been guided to it through the clinician or a provider. So it's from what I have seen, it's usually the parents saying, "Hey, we were referred to this this one-stop shop." And they were able to answer some questions and then be guided to where they needed to go. So thank you for that. Are there any other questions? Okay, thank you very much.
Thank you. Moving on to agenda item 9, for information only, update on denial of rights in seclusion and restraint reporting. Kristen.
Hello. Hello, and thank you for the opportunity to be on your agenda today. I'm really here to inform you that the Planning and Evaluation Unit within the Division of Child and Family Services is still actively processing seclusion and restraint reports that have been submitted from youth psychiatric and/or behavioral health agencies within the state, and are continuing to upload those reports on a regular basis in Teams for the commissioner's review. So they are available to each of the commissioners at any time under their individual channel in Teams that has been set up by DPPH. Also, we are actively working on creating a trends report for seclusion and restraint for youth. And we will be able to present that at one of your subcommittee meetings in the near future. This report will basically outline key data collected through standardized seclusion and/or restraint emergency procedures form that are collected. It will highlight cases based on high-risk indicators, including excessive restraint durations, lack of de-escalation, missing safety planning, and repeat events. So we are actively working on that. And those are the 2 tidbits of information that I wanted to update the commissioners on today.
Great. Commissioner Schrag?
Thank you. Krista, thanks for the heads up on all of that. I know one of the biggest issues that we as commissioners are facing is how we're going to go about being able to review those in a confidential manner. And then recently, Vice Chair Reesley and I had a chance to meet with Richard Whiteley about looking at that, getting back to having that closed session for that. So I know one of the biggest issues is going to be how we go about not just reviewing them, but then having an opportunity to discuss them. So just kind of put that as a little asterisk for all of us, because we're gonna need to do that to provide that oversight, that transparency, ensure that we're keeping up with everything we need to with NRS. And so I know that's going to be something that staff and us will have to collaborate on. And we've had a challenge not being able to get that done. So yeah, it's great that we can review them, but we aren't going to be able to get much done if all we do is just review. We've got to be able to discuss and move through those. So just kind of my little nugget there for us to keep that in the forefront of moving forward.
No, and I appreciate you saying that. You know, the commissioners used to do that on a regular basis on the agenda, and I know just with a little bit of the transition, like you said, that the commissioners have moved away from that. But I did want to let you know that we still are processing them for you.
I don't know that we've moved away from it as commissioners. There was an administrative decision to transition some of that, and I think we'll just need to retool.
Okay.
Yeah, so it wasn't a transition away. It was an administrative decision to move us away from that in the meantime, and it's just something we really need to get back to, because I think it was incredibly insightful, especially when we look at the Never Give Up situation. It gave us insight into activities that were occurring that would not have occurred, in my opinion, in any other way. And it concerns me that we're not doing that. And I believe we still have statutory capability to do it. It's just going to be something we'll have to work through as a collective team. That's all. But thank you for letting us know, because I don't know that we were all aware that they were still being uploaded. And so, as the chair at large of the commission, I just ask that we as commissioners dive in there, make sure that we're taking a look at those, and that we're getting through those. And I'd like to offer that within the next couple of months, if we can look in. I'm sure there's probably a few to review. So just as the at-large portion.
Yes, please. And if any of you have any questions at all, please feel free to reach out to me. I'm more than happy to assist you or to get you in contact with whoever might be able to assist you to process those. Thank you very much.
Yeah, this is Kyra Morgan again. I just wanted to jump in, Chair, and offer myself as a conduit to that conversation. I am recently overseeing the planning and evaluation unit for DCFS, so I'm coming in a little bit late, but I have had discussions with Marla, our administrator, and I would love to touch base with you offline on how we get that going again for you. So maybe we could have a sidebar.
I would love that. Katie, if you could connect the two of us and actually include Vice Chair Reesley in that. I know we've been trying to take lead on that, but if you could connect the three of us, and then we'll find some time. Kira, I'd love to make sure that we get that done. And we had some great advice from Richard recently. And I don't know, Lisa, I see you're up next. Maybe you can add a little to that discussion.
Sure. Lisa Reesley for the record. I just also wanted to throw into this mix. And so, maybe between Katie and Kyra, we need to make sure that whatever we're doing on the children's side, that we have similar or comparable processes on the adult side. So we shouldn't be doing anything different on the children's side than we are doing for adults. And I don't think that in all of these conversations and the changes that were made that we connected the two together. And so I would recommend if we're going to have a conversation about this issue, that we have somebody from the adult side who also participates in it so that we can get on the same page about what we're doing. I think that was an important component of the conversation that we had with Director Whitley, was just like, we have to make sure that what we're doing on one side is what we're doing on the other, and we need to get some clarity around that. So I think that would be another important component to add to the mix.
All right. And Christian, are you the person to contact if we have technical issues with gaining access to Teams?
I can certainly try my best, and if not, I can hook you up with someone who can assist you. But yes, please feel free to reach out to me anytime.
Great, thanks so much.
Of course.
Dan, I think there's been some recent updates with Teams. I think especially for those of us with Mac products, I think the patches have been put in place. But yeah, it should work better.
Okay. Sounds good. Commissioner Cooper, did you have another question, or was it the same one?
Same one. I just have to say that reviewing these forms is one of the things I feel very strongly about, but I can't do it because I can't access my Teams. Once we started at my agency, we started using Teams. My commission abilities to access Teams stopped. So Kristen and Katie, I will be emailing you to figure out what to do.
Great. Thank you. All right. Any other comments on agenda item 9? Okay, moving on to agenda item 10 for possible action, discussion, identification, and approval of future agenda items. I see that there's one here already for determining the 2025 meeting schedule. Is that through you, Katie?
I believed we had already had one set. Is it not?
We can't hear you.
Katie, we can't hear you.
No.
Hi, everyone. This is Carrie, and I provide administrative support to this meeting. My name is Carrie Wilder, and maybe I can assist while Katie tries to reconnect to this meeting. So there's no schedule set, so we have an opportunity here to determine when you want to hold these meetings this year.
Gotcha.
Can you hear me now? I'm sorry.
Yes, thank you.
Turning into an AT&T or Verizon commercial. So yes, as Carrie just said, there are no other meetings set at this time, and so
is there a cadence that we're supposed to be meeting at, or is that up to our discretion as well?
I believe it is up towards your discretion. There isn't anything in the NRS stipulating a certain number of meetings for the subcommittee.
All right. Commissioner Schrage, Commissioner Reesley, is there a cadence that you prefer? Every 2 months?
I'm totally open to how often we meet based on need. Lisa Reesley for the record. I think that we ought to give consideration to the addition of new members who sit on the commission who might be interested in joining the children's subcommittee as well, and then maybe align schedules. So I don't know, maybe if we make a commitment to schedule our next meeting now so that we can engage new commissioners and then set the calendar of meetings for the rest of the year once we have a fuller cadre of members.
That sounds good to me.
Yeah.
I know summer's approaching and people travel and things of that nature, but is there an upcoming Thursday in June perhaps that we can meet? I'm looking through mine, and the 19th is a holiday. Perhaps the 26th?
26 works for me.
I think the 26th works for me as well.
Excellent. That was easy. We'll go ahead and does that need a motion?
No, because it's it shouldn't need a motion because we'll be within, Katie, we should be within we'll be within public meeting notice. Setting a meeting doesn't require. What we'll need to do though is just make sure, I think for this next meeting, we have a very narrowly focused agenda to anybody of course can come, but I think it's more of an administrative and parliamentarian procedural effort to make sure that we're within OML and we do things right. But if we look at setting the agenda to be kind of narrowly focused to determining the 2025 schedule and adding additional subcommittee members and maybe, the open meeting or the public comment, and if there's anything pressing at that time, I think we'll be fine with that.
Yeah, that sounds good to me.
And the only action will be further, but it's not anything we'll have to take a vote on because we're not adding new members. We're just saying, hey, we're going to set a new meeting and not setting the schedule. If we were setting the schedule, then we need to do a procedural vote.
Right.
Katie?
So is this for Thursday, June 26th at 9 a.m.?
Yes, ma'am.
Okay, thank you.
And with that, a limited agenda, I think we can probably be done pretty quickly. So yeah, all right. Sounds good to me. So I don't think that we need any formal action on this agenda item. Are there any other future agenda items we want to discuss at this time?
Lisa Riesly, for the record, what is the process to add the additional members from the commission to our group? Is that going to be an agenda item at our meeting, our next meeting? And then, okay, and so is there a mechanism that those commissioners can communicate to us to let us know that they want to serve on this subcommittee so that we have a complete list?
We can do much like we did when we formed this subcommittee, would be in an open meeting law, have people say they want to do it, and then we as a collective team vote. Then we would need to make sure that whatever that new number is, that moving forward, we comply with quorum. Okay, so perfect. Right now it's just 2 out of 3. If we have 5, it's 3 out of 5, so on and so forth. That it's I believe 2/3, right, Katie?
It's a majority, so
yeah,
half
majority
plus.
Yeah, half plus 1. Yeah. Okay. So yeah, we wouldn't, but I would encourage any in the meantime. Any persons that are wanting to join, please send it over and to Katie, and then she can take care of the distribution to everybody else from there. So we stay within open meeting law.
Perfect.
I believe we have to, and this is not from working with you all, but working with another group, I believe we have to list their names of the individuals interested in
Yes.
joining the subcommittee. So that is why we do need to know in advance.
Yeah.
And just looking at a calendar to be able to finalize the agenda with our timeframes, we would need to have this information. I believe we would have to know which other commissioners are interested in becoming members of the subcommittee by Friday, June 6th. Carrie, do you, not to put you on the spot, but is that give us enough time to complete our agenda process that we have to go through?
Yes, that looks good.
Okay. So then, yes, we can also send we can send an email out as well to all of the commissioners, asking them to indicate if they are interested to respond and let us know by that deadline.
Are they able to state on the record now under this agenda, under the future topic, the future agenda item topic, if they're interested?
I don't see why not. This is Kyra.
Yeah. Thank you. Like I'm looking at the NRS right now and I'm going, I don't think it says that they can't. So
No, there's no prohibition.
yes. Yeah.
So Dr. Jerome and Dr. Dredd, if you want to just put that on the record real quick.
Lisa Dredd, I'll put on the record to please add me to the subcommittee.
Okay.
Thank you.
Dr. Jerome, Greg Dredd for the record. Please add me to the subcommittee. Thank you, Dan.
Cool.
Great. Excellent. Any other comments on agenda item 10? All right, moving on to agenda 11, which is the public comment. I won't read that preamble again. Is anyone interested at this time in making public comment? All right, hearing and seeing none, we'll move on to agenda item 12, which is adjournment. Thank you for everyone for suffering through my first meeting that I chaired. I think it was some good information, and I look forward to meeting with this committee in the larger committee in the future. So see everyone in a few weeks.
Well done, Dan.
Well done, Dan.
Thanks.
Bye, everyone.